We have Dr. Robert Hancock with us this morning. He's going to be giving us a COVID-19 update and Q&A. So without further ado, I'm going to go ahead and turn it over to him. Oh, are you muted?
Yeah, you'll have to be. And turn your volume down. Okay, a few technical difficulties here. I'm Rob Hancock. I think I've spoken to the group before a long time ago when y'all first formed. It sounds like things have gone very well since then. I'm going to give just a brief update and go through a couple of things that I think are important for people to understand. And then I want to leave plenty of time for questions. On a good note, I will tell you I actually just got a text from my internal medicine doctor. Baylor is testing an antibody test that not only tells you positive or negative, it tells your actual level of antibodies. So I'm confirmed antibody positive already. So I had COVID-19, never knew it, probably had minimal symptoms or none. So I'm going to participate in that. And if I have a high enough level of antibodies, I'll be donating plasma, which will be used either for research or to give to patients who are extremely sick and need antibody-rich plasma. So things are moving quickly. I had heard Baylor was a month away from this, so I'm really surprised that they already have it in place. I'll probably go later today to do the actual test. So that's good news. It's a test developed by Abbott Labs, so probably a legitimate test. So I want to go through a couple of things with you guys. Basically a 5-minute lesson in virology. So I'm going to give y'all 8 years of education in 5 minutes. I think it's important to understand exactly what viruses are and how they work. It's been kind of entertaining for some of us in medicine to listen to the media throw around terms that they have no clue what they're talking about. They just sound fancy, so they throw them out there a lot. I just wanted to go through really quick and kind of explain what a virus is, why it's so difficult to kill, that sort of thing. I think it helps explain a lot of the issues we've run into with this disease. So on this slide, you'll see this looks complicated. It's actually not that complicated. Basically, up towards the top where it says antigen, that's basically virus. Okay, and the virus is I'll show you another slide in a minute. Basically, just a small. It's not even a living thing, to be honest. It's basically a bunch of DNA surrounded by a cell wall. That's it. Or RNA in this case. COVID is actually an RNA virus, which is just a variant of DNA, which I'm sure everybody's familiar with. So basically, your immune system, when that antigen, which an antigen just means anything foreign to the body, but in this case the virus, comes into the body, your B cells recognize, hey, there's something that doesn't belong here. This is a foreign entity. And so your B cells, they call them virgin B cells because they're just circulating and have never produced antibodies. They're looking for something. They want a job. So they actually attach to the virus, and instead of the virus infecting them, the B cells analyze the virus and determine, okay, if we produce X antibody, then that will take care of the virus. And so what happens, they become activated B cells where all they do is crank out antibody as fast as they can. And then that antibody just attaches all over the virus, and the virus can no longer be effective because it's covered in antibodies. So it can't infect anything. If a virus can't infect a host, it dies. There's no, viruses cannot live without a host. So what happens is you produce millions of these antibodies, they attach to all the virus, and the virus is gone. That process can take anywhere from 4 days, 3 to 4 days in the case of a common cold, to in this case, it seems to take 14 days to 21 days with COVID. The good thing is, after you have been infected with a virus, you develop what are called memory B cells. And these are B cells that remember exactly what worked last time. So the next time that virus gets into your body, your memory B cells immediately say, oh, once again, here it is. And so they dump out antibodies immediately, like within minutes rather than days, because they remember exactly what was effective last time. And so that's why you get immunity from having been infected with something or receiving an immunization, In the case of immunization, the antigen is what they inject, which is deactivated virus. And so in that case, like for instance, flu vaccine, they inject a very weakened form of the virus, and that's why you sometimes get very minimal symptoms from a flu shot. But your body recognizes that as foreign, makes antibodies. So later that flu season, when you actually get the flu, your body immediately dumps out antibodies, and you never know you even had the virus. It never really infects you. So that's basically a very quick immunology lecture. Obviously, it gets a lot more complicated, but that's the basics of it. And that's exactly what happens with this disease when you get it. The problem you're into is when the infectivity or the morbidity of a virus is as great as this one is. And granted, this is not as deadly as the numbers look, but for whatever reason, there's a subset of people whose immune system doesn't function properly with this disease, and it creates a lot of havoc. And we can talk about that a little bit further when we get into Q&A, but it unfortunately, this disease is a little bit different. It makes it a little more difficult to treat and detect. Go to the next slide. So, yeah, that's fine. Can you make that big? Okay. So this is just kind of showing exactly how this virus works, very simplified version. Basically, on the surface of virus, you have little proteins that basically are looking for receptors they can attach to. In the case of SARS, it's a receptor that's called ACE2. For any of you guys taking ACE inhibitors for blood pressure, this is actually the same receptor where the ACE inhibitors like lisinopril, benazepril all work. So the virus actually finds the receptor, and its proteins interact with the receptor proteins, and it basically fools the cell into allowing the virus to come into the cell. So like I said earlier, viruses have no mechanism for reproduction on their own. They can't live on their own. They have to have a host. So they find a cell where they can basically attach via these receptors, and the cell mistakenly allows the virus to come into the cell. Once the virus is into the cell, it hijacks the entire mechanism of the cell. So instead of the cell responding to its own DNA and doing the things that cell would normally do, this thing hijacks it and injects its own DNA, and its own DNA takes over the entire process. And so then the cell's sole job becomes to produce more virus. So you have one virus that enters the cell then creates thousands of viruses to the point the cell finally dies from it, ruptures, all the virus spills out, they all go find other cells, and the process continues until you develop antibodies or you die. The faster this process happens, the more dangerous the virus typically is. That's why things like Ebola are so bad. Those things replicate very fast. They also attach to a wide variety of cells. And so you basically just get rupture of tens of thousands of cells within 2 days. And that's why these people bleed to death, because of just severe tissue damage. And the problem with that is it kills faster than you can produce antibodies in the case of Ebola. So it's one that we all obviously worry about. I'm sure you all remember the big scare with Ebola not long ago. But anyway, that's basically the way it works. It's a very simplified version, obviously, but I think it's important to understand what we're dealing with. And then it makes a lot more sense of why vaccine for this is so important, and why even like convalescent plasma, like I'm going to look at this afternoon, is also very important. On go, the velocities of COVID, which is what I really care about. I don't care about the raw numbers. What I like to look at every day, and I look at, is the velocity of new cases. How fast is it spreading? And that number had peaked and has started to drop off, which is a good thing. That's the number you look at to see if what we're doing is actually effective. And it does seem to be. I think there are probably some seasonal issues that are also helping us right now, which is a little scary because it may go away and come back in the winter. I hope that's not going to be the case, because I think if it goes away for a while, everybody's going to get complacent, and then we'll get a surprise in the winter that it's not going to be. So, but the the numbers are encouraging at this point. I think encouraging to the point that I think they're exactly right to start opening things back up. I kind of hope they'll even go a little bit quicker. The problem is we did such a good job that, especially in Texas, we're not seeing a lot of antibody positive people. We distanced so well, none of us got it, except for obviously healthcare workers. And so the problem is if you don't get a large percentage of people who have antibodies, then you don't develop herd immunity. If you don't develop herd immunity, then you're basically waiting for something bad to happen. I think we're probably a year out from an effective vaccine. If we even can develop one. This thing mutates fairly fast. All RNA viruses do. If it mutates too fast, like the flu, then we're looking at getting like a COVID shot every year, just like you do with the flu, because we may not be able to do a one-time vaccine. That's still being researched. We don't know for sure. I heard yesterday they've sequenced a bunch of these, and there's 30 different strains of it across the U.S. already, which is a substantial amount. So anyway, at that point, I want to just open it up to any questions anybody have.
I do. So they talk about the elderly being the high risk. Is it just the age, or is it age plus health issues?
It is definitely age plus health issues. And I tell people the way I look at it, rather than your numerical age, I consider it to be your medical age. You can have a 35-year-old with diabetes, obesity, and hypertension, and their body functions more like a 75-year-old. Yet you can have a 75-year-old who ran a marathon last week, is in good shape, has minimal medical problems. They're very unlikely to have significant issues. They're more like a healthy 35 or 40-year-old. So it's a little deceptive to go just, say an elderly or older people. And really, I don't consider 60, honestly, in this day and age to be elderly. The CDC does. And if you look at the median age of people that die from this, it's late 50s or 60s. So it's not 90-year-old in a nursing home. These are people not much older than me right now. So I will say the one risk factor universally we're seeing that puts you at the highest risk of dying is obesity, beyond question. People that are obese do not do well. They're harder to ventilate anyway with any disease. These people are extremely hard to ventilate. And so you take somebody who's obese and then put them on a ventilator. For any other reason, they're less likely to come off a vent. The obese people that go on ventilators with this, 90+% of them are going to die. They're far more likely to get severe disease. They don't do a very good job of clearing their lungs. So that's absolutely the number one risk factor. The thing that kind of disturbs me a little bit, though, is that when they talk about comorbid conditions, they include just run-of-the-mill hypertension as one of those. Well, that's over half the population by definition. That's 50, 60% of people over 30 have hypertension, whether they know it or not. So I hate that they include that, because I think it skews people's opinion that, oh, this is only a disease that kills old people with heart problems and other stuff. No, if you're 40 and have hypertension and die from it, they announce that you died, but, well, he had medical issues, he had comorbid conditions. Well, hypertension, if it's treated, it's not really that. So it skews the numbers a little bit to say, oh, 90% of these people that die have comorbid conditions. These could be well-managed chronic medical problems that shouldn't put you at risk. So they're even including people that had never had hypertension, but when they present to the hospital have high blood pressures, which could just be from having the virus itself. They lump them into the category of they have high blood pressure, so they had a comorbid condition, even though they never been diagnosed previously. So it kind of skews that a little bit, which I think is unfortunate, because then it gives people a false sense of security that, oh, I'm young, don't have much wrong with me, I'll be okay. There are outliers, and that's what has made this thing far more different than anything we've ever treated. One, we knew nothing about it. We had to rapidly learn everything about this literally in a 3-week period. And there's no research, there's no data. Nobody shared anything from the military. I'm sure they probably had some information. They didn't share it with us. And so we had to learn quickly. The other thing too, this is very unpredictable. We're just now starting to figure out that this infects the lungs, but also trashes the kidneys in people who have severe disease. So the vast majority of people that are on ventilators wind up on dialysis as well. Probably has to do with the fact that you have ACE2 receptors all over your kidneys as well as in your lungs. but we don't know for sure. But the vast majority of people wind up on dialysis, at least short term, and probably have permanent kidney injury after they recover, as well as permanent lung injury. So it's just nasty. The other thing we found, this just came out in the last week, we're putting all these people on heparin now and thinning their blood. For whatever reason, the virus makes you much more likely to clot. They estimate, that a big percentage of the deaths that have occurred from COVID were all from pulmonary embolism and not from the virus itself. I'm sure y'all heard there were 3 people who were discharged in New York and went to a quarantine hotel after discharge, and they found 3 of them dead the first weekend. And they suspect that probably pulmonary embolism was the culprit, because apparently you stay more likely to clot for an extended period after you recover from the virus. So we've starting these people on heparin immediately, because your risk of heart attack, stroke, and pulmonary embolism goes up dramatically if you're infected.
There was a shot of 45 New York City transit workers that died, and not nice to say, but they all appeared to be overweight.
That's what we're seeing in the people who get extremely sick. The patients I've seen, the ones that have gotten extremely sick, the majority of them are either old, or they're young and obese, or they're old and obese, or they're old and have heart disease, COPD. Smokers don't do well with this. I work in areas where probably 65, 70% of the people still smoke, which is unbelievable. But that's what we're seeing. I will say the very first person I put on a ventilator from COVID was, I think, 39 years old, and she ran a marathon like a month or 2 before, and was in perfect health, probably had a body fat percentage around 13%. Couldn't have been more of the picture of health. And that's the scary thing with this. Although we can put people in these percentages, there's this small number of people, and I say relatively small because I've personally seen several, of young people, for whatever reason, just deteriorate rapidly and get extremely sick and quickly wind up on ventilators. I had to put one of my x-ray techs at the hospital, who's a young, healthy guy, on a ventilator that probably got exposed at work. And actually, at one point, we had 2 of our x-ray techs on ventilators in the ICU. I'm glad to say both of them are off the vent now. Both of them are doing well. I think one actually got discharged this last week from the hospital. But those are the ones that concern me. These are people who, have no reason to get sick. This shouldn't affect them at all. It should be no worse than a cold. But yet, in this percentage of these patients, they deteriorate, and they do it rapidly over hours rather than days. So we haven't figured that out yet. We're really trying to figure out what makes some young, healthy people get so sick. We know the healthcare workers, it's probably because of the amount of virus they inhale. If you look across the board, healthcare workers that get this typically get it far worse than the general population. They tend to do worse. 2 colleagues of mine wound up on ventilators right at the start of this, probably not wearing good PPE. And the thought is, if you're in front of a patient who's really sick, they got a lot of virus, they cough, they spew out a lot of virus, you inhale a lot of virus, and therefore you get sick. The transit workers were probably because they were in an enclosed area. They're probably pretty close face-to-face with people. And the number one thing that caused New York to be such a catastrophe, in my opinion, is probably the subway system in general. You get everybody crammed in a metal tube face to face, and you talk about spread. I mean, you could have 2 guys get on a subway car and infect 60 people. So I'm convinced that that's why we had such a horrible spread in New York, and why we're not seeing it in places like Dallas and places that don't have a huge mass transit system or shut them down early.
2 more questions. Anything with blood types? Does one blood type have a better immune system to it?
No. So they initially thought, and this is kind of based on statistics, it looked initially like certain blood types did better and certain blood types did worse. As we got more data, that seems to have not panned out at all. I never put much faith in it, to be honest. But it's also one of those things, you're stuck with your blood type. So it is what it is. But no, in the end, that turned out to be more rumor than fact. The same thing happened with ACE inhibitors, the blood pressure medications I talked about earlier. they said everybody that's on an ACE inhibitor should come off of it because this affects the receptor, and everybody that's on these drugs, it'll probably adversely affect them. It was all theoretical, nothing scientific. Well, it turned out it had nothing to do with whether you got infected or not infected or how bad you did. But a lot of people jumped on a lot of stuff. The whole hydroxychloroquine thing basically came out of some theoretical research on paper, and then they tested it in the laboratory in basically a petri dish, and it seemed to help. And as it's turned out now, it probably does nothing in humans unless you give high enough doses where you get toxicity to the heart. So that probably won't work out either. There's still research on it, but the last study on it was very discouraging. So we'll have to see.
And the last thing, what about the ears? Can it go in through the ears?
No, it can't go in through the ears. Has to have an avenue to get to the respiratory tract, basically. So nose, mouth are your biggest issue. We wear eye protection all the time, and the CDC recommends eye protection. I think that is just more so because your eyes are so close to your nose, and you're likely to rub your eye and contaminate your face. But there's not a true avenue for it to infect through the eyes. Anybody else have a question?
I do have a question. This is Steve Flynn.
Yeah.
So we have a very good friend of ours at church who's been on a ventilator for a long time, 3 weeks or more, probably. Yeah. So I'm just wondering if you could comment on the effects of coming off of a ventilator after being on that long. The news we're hearing doesn't sound good, but just interested in your opinion.
Yeah. So we've learned a ton, and basically when this first started, some of us, including myself, got on social media, and I was able to talk to in real time doctors from Italy, Spain, and ask them, what are y'all seeing before this gets here? Tell me what's working, what's not working. And one thing we found really quick is putting people on ventilators and actually flipping them over, what we call proning. So they're laying on their stomach on a vent, as you can imagine, technically difficult to do. It requires a lot of nursing work, but these people do far better if you put them on their stomach for 45 minutes out of every hour. Roughly, sometimes they'll go for several hours with an hour break. That has helped. The problem with this thing is once you go on a ventilator, your average time to be on the ventilator, whether you come off the ventilator or die, is over 2 weeks. We've still got 5 people on ventilators at my hospital in Oklahoma that were put on a ventilator when this very first started. We're talking 4 weeks ago now. They were some of our first patients. We can't get them off. 2 of them have been taken off the ventilator and had to be put back on within a couple of hours. Statistically, even with all the stuff we're doing, these people that go on ventilators have roughly a 88% mortality rate. So only 12% of them survive once they go on a vent. That number is changing a little bit. It's getting better as we get better at treating this. So one thing that was kind of interesting, we've always been trained, I've always been trained, critical care doctors have been trained that when somebody has respiratory failure, you need to put them on a vent early. You need to intervene early, get them on a vent early, get control of their breathing. And that works with most diseases. What we found with this, that's absolutely the worst thing we could have done. And we were doing it initially. Thank God we had social media and we could talk to some of these doctors who had treated hundreds of these patients when it got here. And they were telling us, do not put them on a vent. You put them on a vent, you basically are giving them a very low chance of survival. And so people that normally would go on vents, we're putting them on high flow oxygen and having them flip themselves over 45 minutes out every hour. And that has salvaged some people who would have been put on a vent under normal conditions. They just do better. The problem with going on a vent, for whatever reason, when you go on a vent with this, it triggers what's called acute respiratory distress syndrome, or ARDS, I'm sure you all have heard it called. And that's where you develop just severe fibrosis in the lungs. And the problem with ARDS, if you survive, you're going to have long-term lung problems. The people that have survived that have been on vents, I've seen their chest x-rays when they were discharged, and they're horrible looking. There's so much fibrosis. So even the young people who get put on vents and come off are probably going to have long-term lung issues. So hopefully your friend from church will do okay. The fact they made it over 2 weeks and haven't died is actually a positive thing. What you run into too, it depends on comorbid conditions. Other things can make it more difficult to get off a vent as well. If you compile several of those things, it may be impossible. But we have had success. To be honest, at the hospital I'm at in Oklahoma, we have only had, we've had 15 people on vents, and to date only 2 have died. So we've done remarkably well. A couple of those were these young people, which we're going to do better statistically anyway. But then I'm hearing from New Orleans, from friends of mine, they were running at 92% mortality for a long time, and they had hundreds of people on vents. So it is still one of those things that I'll do anything I can treating these people to not put them on a ventilator, only do it as a last resort. So it's really tough. Anybody else have anything? Somebody.
I'm just curious because I don't know what equipment, you know, in the hospital and what every area has available and everything, but you said with the flipping over, it increases your chances of survival. I know they have hospital beds that will rotate the patient. You said it takes a lot of nursing power to rotate these patients, and I'm sure it's probably even not the best just flipping over on your stomach on a bed and compressing your lungs that way. They have beds that rotate the patient, and I'm sure they're really expensive, and I'm sure they're not, you know, as available as a regular bed, but why not use as many of those as possible?
We actually have been using the rotobeds. So historically, hospitals have rented, most of them rent these rotobeds because we haven't needed them for very many things. It's sad to say, but the cost of renting a rotobed, one bed, is about $100,000 a month for the hospital. Fortunately, the companies that have these, because they have been necessary, have been offering them for use basically for free. So we are using them. They're great because you can just, the whole bed will flip over, the patient's restrained to it. And it much easier to prone these people with a rotobed than traditional. The problem is there are very few of these available. So most hospitals either don't have them or have a couple. So it then goes back onto the nurses to do it. And this isn't something new. When I was a med student, we proned patients with ARDS routinely. So we already knew this could be effective. We just weren't sure if it would be effective in this actual infection. But we've been doing it for a long time. It is kind of painful. The downside is flipping patients is a good way for a healthcare worker to get infected. You're close contact with the patient, you're moving a lot, your risk of dislodging your mask or something's fairly high. So it's necessary, but it's one of those that we try to get several people and make sure everybody's cautious when they do it, because it's a really good way to contaminate your workers too.
Hey, Robert, this is Pam. I've heard that there are lots of different exercises, breathing exercises you can do to kind of strengthen your lungs. I was just kind of curious, your thoughts on it.
It's not going to hurt anything. What you're doing basically is just trying to increase your lung capacity, which is a good thing. It also can help you clear your lungs, which is a good thing also. I don't think there's any data to say one way or the other. What I've seen and people have suggested makes sense, and I wouldn't, it's not going to hurt anything for sure.
I know there's a lot of yoga, online that has, essentially what you said, strengthen your lungs, increase your breathing capacities. So.
Yeah, lung capacity is a big issue with this, because when you're infected with this, especially severely, it compromises your lungs. So the more capacity you have, the more reserve you have, the less likely you are to be on a ventilator. So it makes total sense that people would do that. Certainly not going to hurt you.
So does an nebulizer machine be helpful if somebody has that type of issue to begin with? Should they start using it, or just in case they have a hard time breathing?
So I tell people with any infection that already are on a nebulizer machine for either COPD or asthma to start using your nebulizer machine on a regular basis, whether you're short of breath or not. Every 6 hours, take a breathing treatment at least until this gets better. What it does, it prevents you from getting to that point where you get more distressed. Then you have to try to use it as a rescue inhaler or rescue breathing treatment. And then if that doesn't work, you wind up in the hospital. Preemptively doing that actually seems to help. It helps them clear their lungs a little better. When you breathe in, those nebulizer basically just opens up all the air passages in your lungs, which also helps cough out mucus and other stuff. So there's not a real disadvantage to doing it regularly if you're on a nebulizer to begin with. What we have found, and this has been a real issue with my EMS agencies here, I'm the medical director for Roanoke and Westlake, and one of the big issues we're running into is when you do go on a nebulizer, it makes you cough out a lot more virus. And so I basically had to prohibit my guys from giving nebulizer treatments in an enclosed ambulance with these patients, simply because their risk of getting it goes up dramatically, just because you tend to get a ton of virus that's expelled from the patient during a treatment. So we've had to get creative. I've had to actually add some other drugs we can use in lieu of nebulizers. But I've been, obviously I don't want any of my guys to get sick. And so far to date, we've been very fortunate. We've had some scares. We've had some quarantine medics. To date, none of them have been infected, in spite of the fact they've all transported quite a few of these patients. So what we're doing is working. I'm fortunate all of our agencies around here have large stockpiles of PPE. I kind of joked that it's pretty sad that some of my fire departments have higher numbers of PPE than some of the hospitals here. But they've been fortunate from that end.
So the other thing she does, she always carries one of these with her.
Uh-huh.
Is that a last resort, or should you be just inhaling this every once in a while, a couple hours?
If you're getting sick, you got a fever or developing a cough, I would use it every 4 to 6 hours, regardless. If you're not sick, nothing's going on, I would just use it when needed, honestly. But it won't hurt anything. If you're starting to get sick, you're coughing, to go ahead and start using it more often. You don't want to use it more often than every 4 hours. It'll cause tachycardia or fast heart rate, those kind of things too. What you worry about more as people get older, obviously. Young people, I just tell them to use it when they need it. It's not going to hurt anything, but you do worry a little bit about the fast heart rate from it. So, but yeah, if you're sick, I would just use it scheduled, where you're just taking it every 4 hours, a couple of puffs. It just tends to prevent you going into a worsened state where your oxygen levels start dropping and you get sicker.
Anybody else?
Hey, Robert, real quick, it's Darren Davis here. Just wanted to ask you, as far as you know, is the governor and his office, are they seeking scientific and medical advice, or are they approaching their restart here as more of a political approach? I feel like I want to trust the governor and the governor's office, but at the same time, it'd be nice to hear that he's seeking good medical and scientific advice.
Yeah, my understanding is that he is getting input from epidemiologists and state health officials as far as when is the time to reopen. So from the start, and this is just my opinion, but from the start of this, I felt like as soon as we see the velocity of cases start to decrease, that we should move forward with reopening some things. Life is not going to be like it was for a long time. There's not going to be any mass gatherings until there's a vaccine. So you're not going to be going to sporting events. There's not going to be large crowds of people. And one thing we do know is large crowds of people is a very bad thing with this. A good example, there's a town not far from Amarillo called Nazareth, and the first 3 people that got put on a ventilator At my hospital there, all went to a basketball tournament that the school decided not to cancel, even though the state had said you should cancel all large events. And I think to date, there's been 20 cases out of this one small basketball tournament. And it actually, Nazareth's a small town. So for a while, when you looked at charts that said per capita, the most infected cities in the US, Nazareth, Texas was number one. Because I think somewhere around 35% of their entire population was positive at one point, and it was all from this one basketball tournament. So that tells you that, you know, you get large groups of people together, all it takes is one or two, and you can get a lot of cases. So, but I'm sure the governor is. I mean, I think, honestly, if he was only listening to politicians, he would have opened everything up 3 weeks ago, because I think that was the big push in Texas. I mean, it's like I told people, when you see Texas taking away people's rights, you better think it probably is serious. You expect that in some states. In Texas, when it starts to happen, there's something bad going on. I think with this, you know, it's kind of funny because you developed a whole bunch of people who think that they're epidemiologists all of a sudden. And you hear people say, well, look at the numbers. None of this was necessary. Well, how do you know the numbers aren't the way they are because this was necessary and it worked? That's actually more likely than it wasn't necessary. So it's a tough call for the governors. You know, people die from recessions, honestly. Statistically, for every 1% unemployment, there's a certain number of people that'll die. So you start figuring those numbers in as well. And you have to keep that in mind when you start destroying people's income, their lives, that kind of thing. There's bad consequences from that. So I know people like to make it really simple, and none of this is simple, for sure. It's very difficult decisions they're making. I think they did the right thing. I think had they not done what they did, the health system would probably be overwhelmed. As it turns out, we did too good a job, and now all of us are facing hour cuts and pay cuts because we're not seeing any patients because everybody's scared to go to the hospital. I did a interview on CBS not long ago talking about how people need to go to the ER if they're sick. And I told the reporter, if you'd have told me a year ago that I would be on TV telling people to go to the hospital, I'd have said, you lost your mind. We just didn't expect that part of it. And so literally, you know, I have friends that are like at Baylor Grapevine, right? I still have privileges there as well, that on a normal day, they see anywhere from 20 to 30 patients and one doctor. I talked to a friend of mine the other day. He saw 6 patients his entire day. And I think most guys are averaging 10. So you're looking at 50% pay cut because we all get paid based on what we see. So it's been pretty rough. It was hard for me to go to my doctors that work in our facilities and tell them, hey, I know that, you know, you're under bad conditions, you're taking a lot of risk, and by the way, we're going to cut your pay. It's pretty demoralizing. We were actually, I'm backed by a really good company, fortunately. And so we were able to just tell everybody, we're going to withhold a percentage of your pay to stabilize cash flow. When this is over or we get government money from it, we'll give that money back to everybody. So I'm hoping our guys come out of it with a little bit of pay cut because we cut hours, but we've been able to keep their actual pay at least at a reasonable amount. They're definitely not making what they were, but we kind of put a floor number in. So at least we're not, you know, cutting their income by 50 or 60%. I got a bunch of young guys right out of residency with a ton of debt and no assets. And so these poor guys were panicked. You know, some of them had just bought a house and other things. And all of a sudden, you know, they've literally been out for 6 months, haven't accumulated any money. And then, you know, now they're faced with taking pay cuts. So fortunately, my group's been able to stave that off. But I know a lot of guys in Dallas have called me and just said, what can we do? You know, I just got my paycheck and I made 30% of what I made the month before, and I can't pay my bills. So we're feeling it too. And that's what I tell people when they talk about the economy and we need to open back up. It's like, I totally get it. Trust me. I want things to go back to normal as much as anybody, but I also don't want to see the hospital overwhelmed. You know, I don't want to be in a situation where we're having to decide who's going to go on a ventilator, who's not going to go on a ventilator, who's going to get an ICU bed. I talked to a guy in New Orleans. Their ICU was full of all COVID patients. They had turned the recovery room and the OR into a makeshift ICU, and they had turned several operating rooms into ICU beds. And they were still had 30 patients in the ER, all with COVID, that had no beds upstairs. So that destroyed their ability to even put anybody in beds in the ER because they were all occupied. That's what flattening the curve was all about. It never was about getting rid of the virus. It was about spacing this out so that the healthcare system didn't get overwhelmed. Dallas, I think, would be fine. We got so much capacity here, so much ability to expand, that this area, even with a mass outbreak, I think it would be very hard to stress the system. But then you look at my hospital in Amarillo. We're the only facility that has ICU beds, not only in our county, but in the 4 counties surrounding it. So our 40, roughly, we had 30 something, we expanded up to, I think, 40 something ICU beds. That's it. Once those are occupied, there's nothing else for 100 miles any direction. Lubbock is the closest to have more ICU beds. And so I was more concerned about places like that getting overwhelmed. And initially it looked like we were. The first day this hit, you know, I saw 8 or 9 people that were really sick, and I was like, man, this is gonna go really bad. And then it kind of faded off a little bit. We did get at capacity for a little while, but nothing terrible. And in Oklahoma, the hospital I staff has 25 ICU beds. And again, they're the only place for 50 miles any direction that has any ICU capacity. And this is a small critical access hospital. But the problem is, even when you fill up the ICU, nobody's going to accept these patients because every hospital is dealing with the same thing. So it's like I was talking to administration at this place. I was like, we're not going to be able to call Oklahoma City and say, hey, we've got 10 patients we can't get ICU beds for. They're going to say, no, we're saving our ICU beds because we've got a bunch of sick people too. So I've told hospitals that have asked me about it, get ready. If whatever you get, you're going to keep. So you better figure out where you're going to put them. And they've done pretty good. Oklahoma actually mandated every hospital was required to increase ICU bed capacity by 25%. And funding was offered to help do that. And so we converted the recovery room and a few other places into makeshift ICUs. And fortunately, we had 2 separate small ICUs. We made one of them the COVID ICU and the other one the regular ICU. Last thing you want is people already in an ICU with other medical issues getting the virus. They probably won't do well.
So we take our temperature every day. So initially, I think it was South Korea that was taking everyone's temperature if you walked into a building. Was that just an initial overreaction, or does that make sense going forward?
So it does make sense. I think we're going to see that as we reopen. The downside to that is there's a percentage, and it's relatively high, of people with COVID that don't develop significant fever. I got into many fights with the county health department because they had to authorize tests when we first started. Every time I wanted to test somebody, I had to call a bureaucrat that was a non-physician at the Department of Health to approve the test. And one of their criteria was they were following the CDC criteria, which you had to have a fever to get a test. And I said, no, that shouldn't be the case. We all know some of these people don't have fever, and they would refuse to authorize any test on any patient that didn't have a fever. So miraculously, any patient I wanted to test suddenly had a fever, even if they didn't, because that's the only way I could get a test done. It was ridiculous. I had a patient that had a low temperature, which in medicine, a low temperature is worse than a fever. That means you're statistically very likely to not do well. And they were refusing to authorize the test because they didn't have a fever. Their temperature was low. And I finally had to yell and scream until they finally approved it. But I literally spent an hour out of my day trying to get one test done. So the fever thing, it's good for screening is what I would say. If they have a fever, yeah, they need to go elsewhere. Don't be in a crowd. But conversely, not having a fever doesn't mean that you don't have it. So I'm a little concerned that if we start basing everything off temperature alone, that we potentially could get in trouble. The other thing is there's a study that came out not long ago that actually scared a lot of us. They did tests on people who were known exposures to COVID, and they started swabbing them daily to see what their viral load is. In other words, how much virus they had in their respiratory tract. So it looks like people are most contagious between 2 days before they show any symptoms until 1 day after they show symptoms. So what that means is you're potentially most infectious before you get a fever, before you get a cough. And that's the problem with this thing. That's what's scary. The flu, you start coughing, you get a fever, now you're contagious. It's very straightforward. That's one of the ways we contain the flu is you get symptoms, you don't be around your family, you isolate yourself. In this case, you could look and act perfectly normal, not think you're sick and be spreading this particular virus. That's what makes it absolutely difficult to fight, is the fact that you are contagious before you ever know it. And that is the biggest problem with this. South Korea also did some interesting tracking. Basically, if you were a known positive COVID, the government knew where you were 24/7. Stuff that would never happen in the US. I mean, they put trackers on these people. You can imagine how that would go over in Texas if somebody told you that they were going to track all your movements. But that was one of the ways South Korea actually mitigated the thing was if they told you to stay at home, you were positive, you better not leave your house. Bad stuff would probably happen. So it's been interesting to see how other countries have approached it. The U.S. is a little more limited. There are certain things that none of us are going to put up with. I can tell you right now, I'm not going to let the government track where I go or what I do. So I think that it makes it a little more difficult to fight something like this. But I think vaccine's going to be our way out at some point. Herd immunity, I think, is another possibility. We got to open things up more to get herd immunity. The problem with getting herd immunity is they estimate right now only 5 to 10% of the population have antibodies. They did a study in New York, and it's far higher in New York, but it should be. The virus is more prevalent there. Everybody's on top of each other. But you need like 60, 70% people with antibodies to get herd immunity. So that means we're going to have to expose millions more people before we're going to get there. And a percentage of those that get exposed are going to get really sick. Of those that get really sick, somewhere around 25% of them will wind up on a ventilator. And then of those, only 10% will survive. Those turn into huge numbers really quick. And that's when people throw around these things, well, it's only this, it's only this. I'm like, God, 1 to 2% of the US population is a whole lot of people. And if you look at what the Spanish flu did in 1918, it absolutely devastated the world, but it killed, I think, 10% of the US population before it was over, massive numbers. And the second wave of the Spanish flu is what killed everybody, not the first. There's a lot of reasons for that, but it goes to show you that just because we get past this first wave of this virus, you can't really let your guard down. It's going to come back. And until we have some way to defeat it with a vaccine, we're going to be dealing with this going forward.
How far out do you think we are in terms of testing people for those antibodies? Like, we suspect that somebody did have the COVID-19 virus, survived, everything was fine, it was very mild, but testing to see if they have those antibodies. Like, my daughter came back from London, she's 11. A couple days after she got back, she was sick. I suspect, obviously, that was already at a level 3. So she did a required quarantine and everything and came out just fine. So how far off are we in terms of testing those antibodies to see if we get that herd?
Yeah, there's actually quite a few tests already available. A lot of primary care physicians have these. What I will tell you is, and I actually got a hold of some experimental tests to evaluate, and they seem to be pretty accurate. That's how I found out that I was antibody positive. And these are very simple tests. They look like a pregnancy test basically, but they will detect circulating antibodies. So they're good in the fact they'll tell you have antibodies. The downside to them is they don't tell you what level of antibodies you have. So they're available right now. Now, what I'll tell you right now, there's only 4 tests approved by the FDA, and there are probably 100 of these in circulation. Some of these are cheap Chinese knockoffs that, if you believe anything from China, you're not being very smart, but you do want to find out where they built in America, were they Chinese? The ones I got were from a company in New Jersey that wanted me to try them just to see if we might be able to use them on our EMS personnel. And so I do think that they're accurate. A lot of them were developed under emergency use authorization from the FDA. So it was kind of the Wild West because people could just throw whatever tests they wanted to out at the market. But now that we've got some that are FDA approved, we know they're accurate. It's an easy, quick way to test people. It takes 15 minutes start to finish to run the test. More importantly, this thing that Baylor's trialing with the Abbott test, it tells you your level of circulating antibodies. And their rule is right now, if you want to be tested on this experimental basis, then if you're positive, you have to give plasma, which I think is totally fair. So we'll see, but I think this will probably be available to the general public where your doctor can just write an order. You go to the lab, they draw your blood. Within a day, you have your antibody level. And that's what we really need is we need hard data to see where we're at. I've said from the very first when this started, until we get good antibody testing, we don't know anything. We're flying blind. And anybody that tells you they know what's going to happen is nuts because we don't know. But once we get antibody testing, we know the circulation, people in the circulation or population that have antibodies, it makes it a lot easier if there's a way to give these people some type of card or something to say they're antibody positive. So when we open back up, they don't have to worry about getting their temperature checked or some of the other rules. But what I'll say too, there is no proof right now that having antibodies is 100% or that it even totally prevents you from getting the virus. Scientifically, it should, no question. And I think it does, but we just don't know 100%. There's a lot of arguing between the CDC and the World Health Organization over this. I go with the CDC, which seems to feel that it does offer immunity. The World Health Organization saying it may not. I don't trust anything the World Health Organization says at this point. So from a scientific standpoint, having antibodies should protect you from getting it. But we'll get more data on that. That's easy to test. We'll find that out in the next couple of weeks. But I think that's key to opening back up is antibodies. I think we're about out of time. Does anybody have anything else?
Can y'all hear me?
Yes.
Unmute.
Okay, we're gonna switch. Okay.
Thanks, Robert.
Thank you, Robert, for doing that. You did a fantastic job, and I know it was very informative for everybody. I know we're kind of over time here, but I think